The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. Thank you for joining me today. My name is Christine Reckenberg, and I am a 2018 graduate of St. Louis College of Pharmacy and the current PGY1 resident with the college in the St. Louis County Department of Public Health. Again, thank you for joining me to discuss the new guidelines that provide recommendations for aspirin for primary prevention of cardiovascular disease. I hope this presentation is informative for everyone. If anyone has any questions, I will save time at the end to address them. You should have a questions box on your screen. Feel free to type the questions in there as they arise. I have no conflicts of interest to disclose. My goal is that at the completion of this presentation, you will be able to define recommendations in the 2019 ACC/AHA guidelines for primary prevention of cardiovascular disease. Throughout this presentation, I will use a number of different abbreviations. They are listed here for your reference should you need them. Before we get started, I just want to provide a brief overview of what we will be covering today. We will start off with some background information, then move into some key recommendations from the guidelines. And lastly, we will move into recently published literature that led to some of these new recommendations regarding aspirin use for primary prevention. We will start first with some of the general background information. Cardiovascular disease is a serious problem and has become the world's #1 killer. Approximately 17.9 million people die each year from cardiovascular disease, which is about 1/3 of all deaths worldwide. More than 75% of these deaths occur in low-income and middle-income countries, with 85% of these being due to heart attack and strokes. We are all probably aware of what cardiovascular disease is, but as a brief reminder, this condition is a group of disorders of the heart and blood vessels and can include a number of different conditions. This can be diseases impacting blood vessels that supply the heart muscle, the brain, and the arms and legs. It can be due to damage to the heart muscle or valves, or due to malformations of the heart or even blood clots. As mentioned on the previous slide, heart attacks and strokes are two of the most common causes of death from cardiovascular disease due to loss of blood flow to the heart or brain. One of the most common causes for this lack of blood flow is the buildup of fatty deposits within the blood vessels. This can be due in part to a number of different risk factors. These include a number of modifiable risk factors, such as unhealthy lifestyles, which can include things like an inadequate diet and lack of physical activity that can contribute to weight gain and obesity. Additional factors include uncontrolled chronic disease states, such as diabetes, hyperlipidemia, and hypertension. Lastly, these modifiable factors can include social factors, such as tobacco use. One of the focuses of the 2019 ACC/AHA guidelines for primary prevention of cardiovascular disease is the management of these modifiable risk factors. We will briefly discuss some of the risk factor management here. We will start first with the lifestyle recommendations. These include diet and exercise. The new guidelines recommend a plant-based and Mediterranean diet with increased fruit, nut, vegetable, legume, and lean animal protein with high fiber, as this has been associated with a lower risk of all-cause mortality compared to standard diets. Exercise is also a cornerstone in improving cardiovascular health. The guidelines recommend that adults engage in at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous activity per week to decrease ASCVD risk. Additional risk factor modification involves controlling weight, which can be assisted through diet and exercise, gaining adequate control of diabetes, hypertension, and blood cholesterol, as well as focusing on smoking cessation to decrease ASCVD risk. These guideline recommendations bring us to our first key takeaway, which is to focus on risk factor management to help decrease the risk of developing cardiovascular disease. Now that we have reviewed risk factor modification, we will transition into a discussion regarding aspirin for primary prevention. Before jumping into the guideline recommendations and supporting literature, I first would like to review some definitions. On the left, we have risk factors for bleeding that are defined in the guidelines. These include history of GI bleeding, peptic ulcer disease, or bleeding from other sites, age greater than 70 years old, thrombocytopenia, coagulopathy, CKD, and concurrent use of other medications that increase bleeding risk. Additionally, the guidelines define low-dose aspirin as 75 to 100 milligrams by mouth daily, and the pooled cohort equation is recommended to be used to calculate the 10-year ASCVD risk. Before we can determine if it is appropriate to initiate an agent, whether that be statins or low-dose aspirin for primary prevention of cardiovascular disease, it is necessary to determine the patient's cardiovascular risk. The guidelines recommend that if a patient is between the ages of 20 and 39, that traditional ASCVD risk factors be assessed every 4 to 6 years. Additionally, a lifetime risk can also be calculated for this patient population. And for those individuals between the ages of 40 and 75, the 10-year ASCVD risk should be calculated using the pooled cohort equation. For those patients that are at a borderline or intermediate ASCVD risk, it is appropriate to consider a number of different additional risk factors, such as coronary artery calcium scoring and chronic disease states, some of which are listed here to assist in determining the appropriateness of an agent for primary prevention of ASCVD. This brings us to our second key takeaway of the importance of assessing ASCVD risk prior to making decisions about preventative interventions, whether that be statins or aspirin. Now we will focus on the newer literature that explores some of the specific patient populations that we may consider aspirin for primary prevention. There are a number of new trials that were published late last year and early this year that focus on different aspects of aspirin use for primary prevention. The first one here is the ASPREE trial, which focused on a healthy elderly patient population. The ARRIVE trial focused on a younger patient population with a moderate ASCVD risk, and the ASCEND trial focused specifically on patients with diabetes. And the last listed here is a meta-analysis that was published earlier this year that examined a number of different randomized controlled trials that evaluated the use of aspirin for primary prevention. The first study we will go over is the ASPREE trial that was published as 3 separate publications in the New England Journal of Medicine last year. The aim of this study was to clarify the role of aspirin in the healthy older adult patient population. This was a multi-center, double-blind, placebo-controlled trial that followed patients for a median of 4.7 years. It included roughly 19,000 patients that were randomized to either aspirin 100 milligrams daily or placebo. As mentioned, the study focused on the elderly patient population and therefore only included patients that were at least 70 years old. It also focused on those that did not have pre-existing cardiovascular disease, dementia, or disability, and excluded those patients that were known to be at a baseline high risk of bleeding. The primary outcome of this study was a composite of death, dementia, or persistent physical disability. Secondary outcomes included a composite of fatal coronary heart disease, non-fatal MI, fatal or non-fatal stroke, or hospitalization for heart failure. The primary safety outcome was major hemorrhage. When looking at the results of the primary endpoint, you can see here that there was no difference in the composite of death, dementia, or persistent physical disability with a non-statistically significant hazards ratio of 1.01. In addition, there were no differences in the secondary efficacy outcomes. However, we do see a difference between the aspirin and placebo groups in terms of major hemorrhage. Patients in the aspirin group were 38% more likely to experience a major hemorrhage than those receiving placebo. The study does have some limitations, such as low adherence rates, lower rates of cardiovascular disease than expected, and limited external validity, but overall, the ASPREE trial shows us that aspirin does not improve disability-free survival, but does increase major bleeding compared with placebo in an elderly healthy patient population. The results of the ASPREE trial assisted in the development of the recommendation that low-dose aspirin should not be administered on a routine basis for the primary prevention of ASCVD among adults greater than 70 years of age. The second recently published randomized controlled trial is the ARRIVE trial that was published in Lancet in 2018. This trial was designed to help further clarify the role of aspirin, specifically in a patient population that is at a baseline moderate risk for developing atherosclerotic cardiovascular disease. This study was a multi-center, double-blind, placebo-controlled trial that followed up with patients for a median of 5 years. It included roughly 12,500 patients that were randomized to aspirin 100 milligrams daily or placebo. As mentioned, the patient population included patients at a moderate cardiovascular risk and excluded those with histories of vascular events, those receiving concomitant antiplatelet therapy, and those that had a high bleeding risk or pre-existing diabetes. The primary outcome was a composite of time to first occurrence of confirmed MI, stroke, cardiovascular death, unstable angina, or TIA. Secondary outcomes included a composite of time to first occurrence of cardiovascular death, MI, or stroke, and individual components of the primary outcome. There was not a statistically significant difference between the aspirin and placebo groups in terms of the primary outcome, with a non-statistically significant hazard ratio of 0.96. There were also no statistically significant differences in the intention to treat population for any of the secondary efficacy endpoints. However, when looking at the safety endpoints, there was a statistically significant increase in GI bleeding in patients in the aspirin group compared to those in the placebo group, with a hazard ratio of 2.11. The bottom line from the study is that despite the limitations of lower than expected event rates, limited external validity, and exclusion of patients with diabetes, aspirin does not provide a benefit in patients that are at a moderate ASCVD risk, but does place them at an increased bleeding risk. So the last of the recently published randomized controlled trials is the ASCEND trial that was published in the New England Journal of Medicine in 2018 that evaluated patients who may be at a baseline increased risk of ASCVD due to diabetes. The objective of this study was to evaluate the use of low-dose aspirin in a population of patients with diabetes without pre-existing cardiovascular disease. Similar to the previous two studies, this was a multi-center, double-blind, placebo-controlled trial that followed patients for approximately 7 years. This included roughly 15,500 patients that were randomized to aspirin 100 milligrams daily or placebo. As mentioned earlier, all included patients had a diagnosis of diabetes. They were also at least 40 years old and did not have pre-existing cardiovascular disease. The primary outcome was the composite of time to first non-fatal MI, non-fatal stroke excluding confirmed intracranial hemorrhage, TIA, or death from any vascular cause excluding confirmed intracranial hemorrhage. For safety outcomes, the study also evaluated the first occurrence of any major bleeding event. When looking at the results of the primary endpoint, aspirin was associated with a 12% relative reduction in major cardiovascular events as compared to placebo, as you can see here, with a statistically significant rate ratio of 0.88. The primary safety endpoint indicated that aspirin was associated with a 29% increase in major bleeding as compared to the placebo group, with a rate ratio of 1.29 that was also statistically significant. Overall, the study had a number needed to treat of 91 and a number needed to harm of 112, indicating that although there was a statistically significant benefit in the primary efficacy outcome, the gap between the relative benefit and the relative harm was narrow. One major limitation of the study was that it did not have a large representation of patients at a higher cardiovascular risk, indicating that a blanket statement cannot be made for patients with diabetes regarding aspirin use for primary prevention. Rather, the decision needs to be made on a patient-by-patient basis, focusing on cardiovascular disease risk. To conclude our brief review of recently published literature, we can look at the systematic review and meta-analysis published by Zhang and colleagues in JAMA in January of this year. The purpose of this study was to help further assess the association of aspirin use for primary prevention with cardiovascular events and bleeding. The study included a total of 13 randomized controlled trials in over 150,000 patients with no known pre-existing cardiovascular disease. The primary outcome was a composite of cardiovascular mortality, non-fatal MI, and non-fatal stroke, which could be ischemic or hemorrhagic. Patients receiving aspirin for primary prevention were 11% less likely to experience a cardiovascular event than those in the control group with a statistically significant hazard ratio. The primary safety outcome was major bleeding. Patients in the aspirin group were 43% more likely to develop major bleeding than those in the placebo group with a statistically significant hazard ratio. Here, the number needed to treat was 265 and the number needed to harm was 210, indicating that more patients would be harmed by a major bleeding event than those that would prevent a cardiovascular event. Now that we've reviewed additional primary literature, this brings us to our final two takeaways. When we consider older trial data in combination with all of these recent studies, it leads us to question the benefit of low-dose aspirin for primary prevention of cardiovascular disease. For this reason, the new recommendations by the ACC-AHA guideline is that low-dose aspirin can be considered in patients 40 to 70 years of age at a higher ASCVD risk and low bleed risk. This recommendation now has a lower level of evidence at Class 2B and is characterized by removal of a specific ASCVD risk score for inclusion for aspirin consideration, meaning that instead the whole patient picture should be considered, including ASCVD risk scores, additional risk enhancing factors, and patient and clinician preference. Especially when we take into consideration the results of the ARRIVE and ASCEND trials, the use of aspirin in patients at a moderate ASCVD risk needs to be individualized. Lastly, all of the studies we reviewed today indicated that aspirin use places patients at an increased bleed risk compared to those receiving placebo, leading to the continued recommendation that aspirin should not be used for primary prevention regardless of age in adults who are at an increased bleed risk. I hope these takeaways have been helpful in providing a quick update to the new ACC-AHA guideline for the primary prevention of cardiovascular disease. Now that we've completed the presentation portion of the webinar, I'd like to move into a few brief assessment questions. I will start by reading the question and answers, and I will give you a moment to think about the answer, and you can type your choice into the question box so that I can see your response. Then we will review the correct choice. So first, which trial showed no difference in cardiovascular disease composite endpoint in a population of patients 70 years of age or older? Is it A, the ASPREE trial, B, the ARRIVE trial, or C, the ASCEND trial? The correct answer is A, the ASPREE trial. So the ASPREE trial included healthy patients that were 70 years of age or older. The secondary endpoint of the study was a composite of cardiovascular disease, which included fatal coronary heart disease, non-fatal MI, fatal or non-fatal stroke, or hospitalization for heart failure, which was not found to be statistically significant with a hazard ratio of 0.95. And this brings us to our final assessment question. So a 75-year-old white male patient with no significant past medical history is considering initiating aspirin 81 milligrams daily for primary prevention of a heart attack. Based on the 2019 ACC-AHA guidelines for primary prevention of cardiovascular disease, what is the best recommendation? Is it A, low-dose aspirin may be considered if the patient is not at a high bleeding risk, B, low-dose aspirin should not be considered, or C, low-dose aspirin is recommended? And the correct answer is B, low-dose aspirin should not be recommended. So the 2019 ACC-AHA guidelines provide new recommendations for aspirin use in the older patient population. According to the guidelines, low-dose aspirin of 75 to 100 milligrams daily should not be administered on a routine basis for the primary prevention of ASCVD among adults over the age of 70. That concludes the presentation. What questions do you have? Okay, it looks like there are not any questions. I apologize again for the problems with the technology here. I did want to let you know that within an hour, you should receive an email with the details on how you can obtain CE credit for participating in this activity. Thank you again.